February 30th, 1:05, and today we have in with us our legislative counsel to go over, I think we got a really comprehensive state of affairs, I would say, from the Green Mountain Care Board. And, there have been legislative action in the past addressing some of that, and that's Act 167. And I wanted Jen to give an overview of what we've done in the past and what we've set in motion. And we'll hear about that more tomorrow, just to let you know. Go ahead, Jen.
Great. Good afternoon. Jen Carby from the Office of Legislative Counsel. So yes, I'm going to share with you both Act 167 of 2022. It's important because there's always, every biennium just about, depending on how high the Act numbers get, there's always an Act 167. So we're talking about Act 167 of 2022. And I'll just show you a little bit of the language, but then really what I'm going to show you is just a one-page summary I prepared in advance of the Health Reform Oversight Committee meeting in December, because I think it's helpful to see everything kind of on one page. So Act 167 was entitled an act relating to healthcare reform initiatives, data collection, and access to home and community-based services. Generally, when we're talking about Act 167, we're really talking about sections 1 and 2, and then there was actually a section 2A added to it in the following biennium. And so the section 1 dealt with the development of a proposal for a subsequent all-payer model agreement. And it had some considerations in it that the Director of Healthcare Reform in the Agency of Human Services, in collaboration with the Green Mountain Care Board, had to keep in mind while developing a proposal for a subsequent agreement with the federal government. That's the Center for Medicare and Medicaid Innovation, which is part of the Centers for Medicare and Medicaid Services, to secure Medicare's sustained participation in multi-payer alternative payment models in Vermont. So lots of things to keep in mind: total cost of care targets, global payment models. We've started talking a bit about that in here. Strategies and investments to strengthen access to certain types of care. Strategies and investments to address health inequities and social determinants of health. And the role, if any, of accountable care organizations in Vermont's multi-payer alternative payment models going forward. It also directed consideration of alternative payment and delivery system approaches for hospital services and community-based providers, with certain types of those included, and then directed that specifically certain alternative payment models be explored, including at least value-based payments for hospitals, including global payments. So that's a term, global hospital payments, you may have heard about, or global hospital budgets in here, that take into consideration the sustainability of Vermont's hospitals and the state's rural nature. Also statewide, regional, and hospital-based global budgets for healthcare services, or a combination, existing federal value-based payment models, and broader total cost of care and risk-sharing models to address patient migration patterns across systems of care, where patients may come in or out of the state, or in or out of different levels of services or different service settings. The proposal must include appropriate mechanisms for converting fee-for-service reimbursements to predictable payments for multiple provider types, include a process to ensure reasonable and adequate rates of payment and a reasonable and predictable schedule for rate updates, meaningfully impact health equity and address inequities in terms of access, quality, and health outcomes, and support equal access to appropriate mental health care that meets standards of quality, access, and affordability equivalent to other components of healthcare as part of an integrated, holistic system of care. Required the Director of Healthcare Reform, again in collaboration with the board, to ensure that the process for developing the proposal included opportunities for meaningful participation by a full continuum of providers, payers, participants in the healthcare system, and other interested stakeholders at all stages. It's supposed to be a simple and straightforward way for interested stakeholders to provide their input, allowed the process to use existing local and regional forums, to promote engagement with diverse stakeholders and ensure prioritization of health equity. And then, so that was all focused on kind of the director of healthcare reform. And then we have some direction at the Green Mountain Care Board. And so now they are, instead of the Agency of Human Services collaborating with the Green Mountain Care Board, we have in this part, the Green Mountain Care Board collaborating with the Agency of Human Services and using that same stakeholder process, build on successful healthcare delivery system reform efforts by developing value-based payments, including global payments from all payers to Vermont hospitals or accountable care organizations or both, that will help the hospitals move away from fee-for-service, provide the hospitals with predictable, sustainable funding that is aligned across multiple payers, consistent with the principles set forth in 18 VSA Section 9371. These are sometimes referred to as the Act 48 principles. They were enacted in Act 48, which was looking at the unified universal healthcare system, but they were codified also under the Green Mountain Care Board. And that are sufficient to enable the hospitals to deliver high-quality, affordable healthcare services to patients, take into consideration the necessary costs and operating expenses of providing services, and not be solely based on historical charges. Take into consideration Vermont's rural nature, including that many parts of the state are remote and sparsely populated. And they're supposed to determine how best to incorporate value-based payments, including global payments, into the board's hospital budget review, ACO certification and budget review, and other regulatory processes, including assessing the impacts of regulatory processes on the financial sustainability of Vermont hospitals and identifying potential opportunities to use regulatory processes to improve hospitals' financial health. Recommend a methodology for determining the allowable rate of growth in Vermont hospital budgets, which may include using national and regional indicators of growth in the healthcare economy and other appropriate benchmarks, as well as other metrics that incorporate differentials as appropriate to reflect the unique needs of hospitals in highly rural and sparsely populated areas of the state, and consider the appropriate role of global budgets for Vermont hospitals. And there were some reports to come back on all of this, which they did. So by January 15th of 2023, the Director of Healthcare Reform and the Green Mountain Care Board were each supposed to report on their activities. By March 15th of 2023, the Director of Healthcare Reform also was to provide an update on the agency's stakeholder engagement process. That was all Section 1. Section 2 is hospital system transformation, and this is an engagement process and a report. This section directed the Green Mountain Care Board in collaboration with the Director of Healthcare Reform in AHS to develop and conduct a data-informed, patient-focused, community-inclusive engagement process for Vermont's hospitals to reduce inefficiencies, lower costs, improve population health outcomes, reduce health equities, and increase access to essential services while maintaining sufficient capacity for emergency management. It directed a lot of parts of the engagement process, so coordinating with the process that AHS was supposed to engage in Section 1, hearing from and sharing information about the current and future states of the hospital delivery system with their communities, also hearing about unmet healthcare needs and opportunities and resources needed to address those needs, providing meaningful opportunities for meaningful participation in all stages of the engagement process by a number of different stakeholders, providing the data, information, and analysis necessary to support the engagement process, and a lot of information about that. And then establishing ways to establish the impact of any changes to hospital services on non-hospital providers, including on workforce recruitment and retention, and determining what resources would be needed to support hospitals in implementing the transformation initiatives developed as a result of the process. And the board was directed to provide an update by January 15th, 2023 on its community engagement process. And then there were funds appropriated as well. So $900,000 from the general fund to AHS in fiscal year 2023 to support its work, and $4.1 million to the Green Mountain Care Board to support its work, including hiring consultants. I'm going to take this down and just put up now my one-page synopsis of all of this, because I think there's a lot of words to look at. So to the extent it is helpful, here's how good. Here's how I synthesized it. So again, section 1 was around the development of a proposal for a subsequent all-payer model agreement. That AHS was supposed to take the lead in developing a proposal for a subsequent agreement with the federal government to ensure Medicare would continue to participate in our multi-payer alternative payment models. And it directed the board in collaboration with AHS to figure out sort of how to work value-based payments and global payments and global budgets into their regulatory processes. And there was a hospital system transformation process. And then in an act from 2023, there was additional language sort of added retroactively to Act 167, directing AHS to engage in transformation planning with up to 4 hospitals, with a progress update due to the legislature by February 15th of 2024. There was the funding, and then I listed the deliverables that were required, and there's links to all of these. So AHS had to provide updates on its Section 1 activities and the board on its Section 1 and 2 activities. In January of 2023, AHS stakeholder engagement update in March 2023, and then the board, through its contract with Oliver Wyman, produced the community engagement report as part of Section 2.
So we can say Section 2 is the Oliver Wyman report.
Believe so.
Everybody-
I think, you know, the way Act 167 is constructed and what came out because of what I would defer to the board about exactly which parts of Act 167 they were following in each piece of their work. They're a little sort of circular.
Could we say that when we hear about things like the AHEAD model, would that sort of be Section 1?
I believe so, but again, I would, I think the AHEAD model came to us more than Vermont developing a proposal based on the language in Section 1. But I think some of the work that's going on is about kind of aligning Vermont's goals in Section 1 with what's available through the AHEAD model.
This is a great summary.
It is. I'm just looking at some of our budget requests. I think in the BAA, didn't AHS have money they wish to have appropriated to engage the transformation planning with hospitals?
I believe so. They were given, you know, as you saw here, they were given 900,000 in fiscal year 2023 for their work. It sounds like this may be the next iteration of resources they're requesting to continue that work.
Right. So tomorrow we're going to hear sort of where we are in the process, what has happened in the process, the results so far, and then moving ahead. And when I say ahead, I mean like actually moving forward with where we are in the process and what else we're working on. Does anyone have any questions about? Did everyone have fun reading the report this weekend? Do you like that report?
Yeah, I do. It has a lot of graphics in it.
Oh, it's good. No questions about it? All right. Thank you.
Yes.
And thank you for reminding us some of the work that we did. And I've also asked Jen to go through sort of a small history of the work we've done around telehealth.
Yes, I was planning to talk a little bit about sort of what it is and then look at what we have in
Yes.
statute on it. Which I'm realizing I left out one big part, so we'll talk about it.
Yeah, and I thought that was important because we do have a bill on telehealth around on our wall right now. So
Okay.
move to
All
telehealth.
right, so a completely different topic, telehealth. So when we talk about telehealth, we are usually talking about, when I use the term telehealth, I'm talking about kind of a broad umbrella that includes a few things. One of them is what is referred to as telemedicine. And it was a lot harder to explain prior to COVID and the Zoom era. But if you think of it as basically seeing your doctor on something like Zoom. So there are certain requirements in order for the provider to actually be able to use a platform to meet with patients. But it's a live audio video interactive meeting where you are talking to a provider in real time. And that is generally referred to as telemedicine. Also under the umbrella of telehealth are things like audio only telephone. So this is when you talk to a provider on the phone, but they're not looking at you and you're not looking at them. And generally what we're talking about here is not just talking to your doctor's office about an appointment or asking a question of the staff, but really receiving some kind of health services over telephone. And again, during COVID, that really picked up and became a lot more recognized as a way of delivering care. There's other aspects like store and forward, where there might be some images or recordings or other materials that are provided to a healthcare professional to review, not in real time with the patient. So it might be from one provider to another provider regarding a patient, or something that a patient sends to their provider that the provider is looking at, but not in real time. So asynchronous, as opposed to synchronous, is in real time. Asynchronous is not at the same time. And there's also things like remote home telemonitoring, where a patient might be at home, but able to provide some information to the provider's office about weight, blood pressure, blood sugar, things like that, that allow a healthcare provider, and often this is a home health agency may have make some use of this, is able to monitor how a patient is doing without having anybody go out to the house or without having a visit. But if something looks unusual or concerning, that can be responded to much more quickly than just waiting for somebody to report a problem. So that's the broad umbrella of telehealth. Often when we're talking about it, we're really thinking of the telemedicine and audio only. But so I'm going to now show you, we have some statutes around, so we regulate it in a few different ways. We regulate how the providers deliver services using telehealth, or telemedicine, and store and forward is what those are focused on, and then also audio only. So what the healthcare professional is doing when they're delivering care in that manner. And then we also have how it's paid for. So what insurance and Medicaid have to cover when a patient is seeing a provider or interacting with a provider over telehealth. And then the part I did not include in here, although we certainly can, is that during COVID, as this became more and more prevalent, there was interest in allowing healthcare professionals from other states to become licensed or registered in Vermont to provide specifically telehealth services. So it's something short of a full licensure to provide in-person services in Vermont. And it's depending on the number of patients they're seeing and the frequency with which they're seeing different patients. They might seek either a registration, which is sort of a short-term, or a telehealth license, which is a longer term, for a year and renewable. Yes.
Healthcare services generally, for licensure purposes, follow the location of where the patient is, not where the provider is.
That's right, exactly. So generally, the provider has to be licensed in the state where the patient is physically located at the time the services are delivered. So if you have a patient and a provider in different states, if the patient is in Vermont, then the provider should be licensed in Vermont, even if they are not physically present here. And so with the increase in telehealth, there is more and more proliferation of providers who are maybe licensed in many states, and able to provide care to patients by telehealth to patients in those states. And for Vermont patients, that includes now the ability for that provider to have a telehealth license that is less expensive than and has sort of different parameters than a full license. Thank you for that important clarification. All right, so let's look a little bit of a language here. And I've just basically put together in a single document the statutes, at least around delivery and payment for telehealth in Vermont. So this is in Title 18, doesn't say that, Title 18, Section 9361, we have healthcare providers delivering healthcare services through telemedicine or by store and forward means. Excuse me. And so this says, it's all subject to what license the individual is practicing under. So the ability to do telehealth does not expand the scope of practice of what any individual practitioner can do under their license. So subject to those limitations, a healthcare provider who's licensed in this state can prescribe, dispense, or administer drugs or supplies, or otherwise provide treatment recommendations to a patient after having performed an appropriate examination of the patient in person, through telemedicine, or by the use of instrumentation and diagnostic equipment through which images and medical records may be transmitted electronically. So that generally is the idea of store and forward. Treatment recommendations made by electronic means are held to the same standard of appropriate practice as those for traditional inpatient setting or in-person settings. This does contemplate the ability of a provider who's licensed appropriately to provide both healthcare services and dental services. So that was an expansion that was made at one point, as there has been some expansion in teledental services. And this requires a provider who is delivering services through telemedicine to obtain and document a patient's oral or written informed consent for the use of telemedicine technology before delivering services to the patient. So upfront or before starting to deliver services, they have to get informed consent. And it talks about what goes into that, that the informed consent must be provided in accordance with Vermont and national policies and guidelines on appropriate use of telemedicine within that provider's profession, and has to include in easily understandable language an explanation of the statute speak for pros and cons, the opportunities and limitations, pros and cons of using telemedicine to deliver healthcare services, informing the patient of the presence of anyone else, any other individual who's going to be participating in or observing the patient's consultations. So if there's somebody else in the room with the provider at the distant site, the patient needs to be informed of that and give their permission. And assurance that all the services are going to be provided over a secure connection that complies with HIPAA requirements for a secure connection. And there are specific requirements in addition to all the other HIPAA stuff you're aware of around privacy of protected health information about the security of that connection. Specifies that for services that are going to be delivered through telemedicine on an ongoing basis, the informed consent is only necessary to get at the first episode of care. And then the provider has to include the written consent in the medical record, or if it was oral consent, that would be noted in the medical record. Subdivision 3 was looking at was addressing concerns that the insurers raised, that they might have their own third-party vendor that they're working with that might have slightly different parameters. Subdivision 4 gives some exceptions to when informed consent is necessary. So if there's a medical emergency, it's not necessary. If telemedicine is being used for the second certification of an emergency exam to determine whether someone is a person in need of treatment, they can be done by telemedicine, but they do not have to get informed consent for it to be done by telemedicine. And also for a psychiatrist's examination to determine whether someone is in need of inpatient hospitalization. Those are the exceptions. D, we will be coming back to, I think, in your walkthrough or your overview later, but under current law, neither a provider nor a patient is allowed to create or cause to be created a recording of a provider's telemedicine consultation with a patient. So currently no recording can be made of that visit. The patient has to be informed of their right to refuse to receive services over telemedicine and to request services in an alternative format. I'm sorry, that was store and forward. If it's store and forward, they have to be informed of their right to refuse to receive services by store and forward and to instead request them by real-time telemedicine or an in-person visit. Receiving services by store and forward does not preclude a patient from getting real-time telemedicine or an in-person visit with the provider at a future date. Doesn't set a precedent that can't be broken. And then originating site providers involved in store and forward must also get informed consent. So that was all telemedicine and store and forward. Then we had a section that was added a few years later regarding services delivered by audio-only telephone. There's no video here. It's in real time, but it's just by telephone. And a lot of the provisions are very similar, but there is significantly more language about recognizing that it may not always be clinically appropriate to deliver services by audio-only telephone. If there's something that involves a visual, the need to look at something visually, then it likely would not be clinically appropriate to use audio-only telephone. And there is, again, requirement that the patient's informed consent be documented in the medical record, but also the reasons that the provider determined it was clinically appropriate to deliver healthcare services to the patient by audio-only telephone. Like with telemedicine, the provider can't require a patient to receive services in this manner if they don't want to, and they cannot delay care unnecessarily if a patient decides they want an in-person or telemedicine visit rather than an audio-only telephone visit. Again, documenting informed consent at the beginning before delivering any services, and similar requirements around getting informed consent for audio only, including who else might be in the room, whether the service will be billed to the patient's health insurance plan if delivered by audio-only telephone, and what that may mean for the patient's responsibility for co-payments, co-insurance, and deductibles, and informing the patient that not all audio-only healthcare services are covered by all health plans. So this is some additional language on audio-only, recognizing particularly in E, there was, I think at the time, significant concern over whether the patient would know when they were just calling to get test results from their provider's office versus having an actual audio-only visit that they would have a copay for and not being surprised by out-of-pocket requirements for something that they thought was just a phone call. So there was concern about kind of where the line is between routine phone calls with the provider's office that people were used to versus having an appointment by audio-only telephone. Then some other provisions around informed consent, again, only has to be done at the first episode of care if there was going to be ongoing audio-only telephone. If the patient provides oral informed consent, the provider must offer them a written copy of their informed consent. Not required to get their informed consent if it's an emergency, and the other two exceptions from the telemedicine one don't apply here. Cannot use audio-only telephone for the consultations in the mental health context, the emergency person in need of treatment or inpatient hospitalization. Again, for future purposes, later today, neither a healthcare provider nor a patient can cause or create or cause to be created a recording of a provider's telephone consultation with a patient, in addition to the telemedicine one we saw above. And then clarifying, you can't use it for the emergency examination about whether someone is a person in need of treatment or for the psychiatrist's examination for whether a person is in need of inpatient hospitalization. So those are the provider-focused ones about how the provider delivers care and what kind of informed consent they need to get. And then we have some provisions around health insurance coverage. And a lot of this is, we won't need to go through word for word, but we do require under Vermont law that all health insurance plans in the state provide coverage for healthcare services and dental services delivered through telemedicine to the same extent that the plan would cover the services if they were provided in person. was a pretty big deal at the time. I think people have gotten more used to it since then. But there's also language that has been added and amended more recently about what the reimbursement looks like to the provider. And under existing law now, fairly recently, on an ongoing basis, the plan must provide the same reimbursement to the provider, regardless of whether the services were provided in person or through telemedicine. And you'll see in a minute, or through audio-only telephone as well. I believe is what we came to. So that was a big change when it happened. Again, people may be more used to it at this point. There are some exceptions, like if there is a value-based contract for healthcare services may look different. There is allowed to be a deductible co-payment or co-insurance charge for telemedicine as long as it's not more than it would have been if the person had gone to an inpatient appointment. Coverage can be limited to providers in the plan's network. The plan cannot impose limitations on how many telemedicine visits a person can have that would be more than limits placed on in-person covered services. And then some details around store and forward and the cost sharing that would apply in store and forward. Mainly sort of narrow provisions, and then a number of definitions, and the definitions are important because they feed into the provider ones as well. So distant site is where the provider is if they're not in the same location as the patient when they're delivering services. Health insurance plan includes Medicaid. Originating site is where the patient is. And when telemedicine was first starting, the patient had to be in another provider's office. So it was sort of provider's office to provider's office. This has expanded significantly over time. And then here's a more thorough definition of store and forward. And then we have coverage of services delivered by audio-only telephone, which also includes Medicaid. And this was even more recent than the telemedicine changes. And again, requires a plan to provide coverage for all medically necessary, clinically appropriate healthcare services delivered remotely by audio-only telephone to the same extent they would be covered if they were in person. And the reimbursement rate must also be the same, which was a pretty big change that was just enacted last year. And the other provisions are pretty much the same as what we were just looking at for the telemedicine. So that's what we have in place currently around telehealth. Is that sort of what you were hoping for?
That's kind of what I was hoping
Great.
for. Woody?
I can't remember, but the insurance rates for telemedicine, are they same as in person?
Yes, at this point, reimbursement rates have to be the same for in-person telemedicine and audio-only telephone.
I don't think I saw anything there about telemedicine or telehealth in schools.
There is nothing specific. I mean, it is allowed to be a setting in which a patient is located when the services are being provided by telemedicine.
It's not treated as a separate site. It's treated the same as any other site that a provider would be or a patient would be receiving services at.
To my knowledge, there is a reference in one place to an example of a person being in a school setting, a patient being in a school setting, and but at this point, there's no limitations on the setting the patient is in when they're receiving the services.
Oh, no, go ahead, Topper.
Does this apply to all alternative type medicine too?
I mean, it applies to all providers. So the definition of a provider is anyone who is licensed to provide professional health services in this state to an individual during their medical care, treatment, or confinement. It's a broad definition of provider. So if it is medically necessary and clinically appropriate as a service to be provided by telemedicine, if it's, I mean, it has to be covered under the plan, a service that is covered under the plan, and it has to be medically necessary and clinically appropriate to provide by telemedicine or audio only. So I think it would be very specific to the particular circumstance. There's nothing that carves out alternative treatments if they are covered by insurance. Did you have a specific?
I did, yeah. I was thinking of somebody below 18 and marijuana or something like that was prescribed to them.
I don't believe it can be, although I would defer to the committees that handle, I don't handle medical cannabis, but this is, so this doesn't get anywhere outside of what is, this is really just a service delivery modality. It's not, doesn't affect whether treatments are or are not permissible to a different extent than they would be when delivered in person. I'm not aware of what the medical cannabis laws are for minors.
Okay. Well, I was just looking at the last thing where it said insurance plan shall not require a healthcare provider to have an existing relationship with the patient.
In order
I think in my
to
memory,
be, in order to be reimbursed for services that they delivered by audio only telephone.
yeah. Well, something I'll just have to look into.
I-
I mean, I think there are pretty strict parameters around when a provider can prescribe cannabis for medical purposes. That I think it would be, may not fit in this context for them to be prescribing by audio only telephone. So you sort of have to match up the provisions of law. This doesn't say, and this is all about a health insurance plan and reimbursement, not what service delivery is permissible under law.
If I may, if I recall at the time, remember, this was all sort of new. We kind of think of it as what happens now all the time. At the time, people were concerned that it would be more appropriate to render telemedicine appointments only to a patient that you had a pre-existing in-person relationship with. And so there was a concern of you could not, it would not be appropriate to see someone for the first time via telemedicine. And I think we put this in there. I mean, if you think about, I like to think about medicine in the context of mental health care, psychological, licensed clinical social workers, therapy. I think there was a concern at the time that you had to see those people in person first to develop a in-person relationship, and that the value of your clinical work would not be the same if you were just meeting them for the first time on, lack of a better word, Zoom.
Oh, so you're right.
And
Because I
that,
was at AHS then, and
Yes.
we were arguing that you had to have already established care with the patient.
yes. And I think that this was
That's-
added because
That's
we were
exactly
like,
right.
there was no basis.
That's exactly right. And again, this is around whether when the insurer has to pay for audio only services delivered to a patient. And so what that language is saying is that the insurer cannot require that the patient already have an existing relationship with the provider in order for the provider to be paid for delivering services by audio only telephone. And I do recall certainly a significant amount of the conversation was around initiating mental health treatment, and that for an individual who was most comfortable receiving it by audio only telephone, the requirement to have an in-person or even video appointment first might be a barrier to them initiating treatment.
I recall. Ellen?
Did I hear you say that once you got your provider and you can do the telehealth, it's unlimited time?
No, it just says it can't be subject to, the insurer can't place treatment, like number of visit appointments on telemedicine, that they would be different than the number of treatment appointments in person.
Okay,
So basically, they're interchangeable in person telemedicine or audio only
okay.
as far as treatment limits.
Can you remind us, particularly around the sections of informed consent? And I'm thinking about the provision that there be no recording or anything, no recording should be made. Can you remind us what year that was?
You're gonna need you to give me a minute.
Okay. What year that we put that in? 2021?
No, it was, I think it was earlier than that.
Yeah, that was
19,
wasn't
1920.
wasn't this all done at the beginning of 2020, right before?
No,
Oh,
this,
okay.
the telemedicine, telehealth provisions have been, not, the audio only was more recent, but no, the telemedicine provisions have been in place longer than that.
Okay.
Just get there. I'll tell you the first year, and then I'd have to go back and look at that act to see which of the years it was. So 2012 is when the legislation around telemedicine was first enacted, and I think it may have been around 2017 that looking at someone who may have been on or near the committee at that point in time. I'd have to go back and look at the acts to see when that specific language was added, but in my recollection, Representative Chino was on the committee at that point. But I think most others were not.
Just, I'm thinking about emerging technologies and things like that.
Yes, if you give me a minute, I can look.
Like last year when we took CD-ROM out of statute.
That is very true.
Are you imagining telehealth with artificial intelligence? I hope not.
I think we're gonna,
Well, that's already happening.
I think we're gonna hear
Are you going a
a
little
little bit
bit
later on this afternoon.
What's that?
Oh, Brian, did you have a question?
Well, I mean,
Oh.
I've been listening to this whole conversation, just like trying to remember exactly how all this rolled out. And if I recall, we passed the telehealth stuff before COVID. And then when COVID hit, it changed everything and it made us rethink a lot of things. And that's, I think, when we shifted away from this idea that you had to see someone in person first, because you were having to start treatment with people who you could not see in person. And there were people whose video wasn't working properly. So we were using audio only Zoom or audio only. And so I think now the current standard of care is like what everything we heard Ledge Council say, that if it's a procedure or approach to treatment, that it's okay to not see the person because you're not physically examining something visually, then it's okay to do it all on telehealth. And in terms of the artificial intelligence piece, this is an issue we're going to have to pick up soon because there is pressure to move towards medical record systems that monitor the entire visit and then write a note for you. And there are definitely pros and cons to that approach. And there's also concerns about artificial intelligence embedded in telehealth and what it's and data collection and things like that. So I do hope we can take some more testimony over the course of the year before we make any decisions.
So, and thank you, because that allowed me to confirm it was 2017 that the language was added about not recording, nobody recording.
That's before my.
Which was before the pandemic.
Which was before the pandemic.
Mm-hmm.
There would be consent be on this person's file then, if there's no recording and there's nothing.
So the requirement is that either there's either written informed consent provided at some point, or that the provider, it doesn't give it exactly, it doesn't say exactly how it works, but that they reduce it to writing, that they make a note
Okay.
to say, informed. So they either have to include the patient's written consent in their record or document their oral consent in the medical record. So, something along the lines of informed consent was received.
What about the patient recording?
That under current law, neither the patient nor the provider can record their consultation.
So what avenue would you have if you got the wrong medicine by human error? There's no record.
Same as an in-person. I mean, it's not that It's not that there is nothing in your medical record about the appointment. It's that nobody can make a recording. So nobody can, record on their phone or have it set up to record the appointment on their device.
But there's got to be a procedure where the doctor is giving this telemedicine to somebody. There's got to be recording of what it is and how much and.
Their same clinic note, same patient visit notes that they do for an in-person
Okay.
visit. And I defer to the providers, but.
Yeah, for sure, like,
That part's the same,
you
yeah.
do exactly the same thing, you
Okay.
could be there, or you could be there, but. it would be
That part's the
exactly-
same.
Yeah.
Hopper?
Can you explain again what you mean by recording?
All I can tell you is what the word says, per se. So, and my understanding of them in sort of common parlance, let me put that back up on the screen. And I can tell you my recollection of the discussion in the committee, but neither a healthcare provider nor a patient shall create or cause to be created a recording of a provider's telemedicine consultation with a patient. And the same language exists for audio only. So as I understand the words create a recording would be to use some sort of a device, whether a phone, a tape recorder, an app on a device that would make such a, I don't know how to not use the word record, but
Transcribe.
but, well, not just, I don't know that transcribe maybe, but so that it was viewable or listenable to again in the future.
I think.
And I think there were some significant privacy concerns, at least when this language was added in 2017, about patients feeling comfortable, being candid with their provider if there was the potential that any recording might be made of it.
Brian, did you have another question?
Good context.
Yeah, well, it was more like just to clarify the difference between a recording and a record. That a medical record is not the same as a recording. Like the issue was that we didn't want people making audio or video recordings of clinical work that hadn't been where that was not a practice before. As opposed to like medical providers always have to keep a health record for every visit, and it's a written record, and the patient has rights to access that record under both Vermont state law and federal law. And when we start therapy with someone or start treatment with someone, we give them a notice of privacy practices for HIPAA that outlines the process for their access to their health record. And so that's very different than a recording, than going into like a visit and like having your phone secretly recording you and your doctor talking, like that. Do you see what I'm saying? So like, I just wanted to say that there's a record for everything, but the record is a written summary or test results or some other thing in writing that's not an actual recording in real time. And the concern, I think, with telehealth is that there are now apps like this Otter app and others that can record an entire Zoom conversation and turn it into a transcript that one party has and the other doesn't. And like, that's an example of like something that I think we would not want to allow, or we'd want to at least take more testimony on before we allow, because it changes the standard of care for telehealth from in person.
Leslie and then Topper.
I think the world has changed a little bit since then, in that there are a lot of older people that live far away from their children and they can't be at the visit, but they want to be. So the phone is on in the room and maybe even recording so that they can help take care of their parents. So I'm not sure. I think it's worth conversation about, we want to be so absolute. If we could temper that language, and I'm not sure what that process would be necessarily, to say unless both parties agree or something, because I've seen it happen.
Hold that thought.
Yes. I think this is something that we may be taking a lot of testimony on.
Okay,
Yeah,
thank you.
To do exactly.
Yeah, there is a bill on this, and I assure you, there will be lots of testimony taken on it if we move forward with it. And we will get into all of these scenarios, particulars.
It's just more
Inside
nuanced.
that.
It's more
Yeah.
nuanced
It's-
now than it
it
was
is.
then, and I just think we need to have
This is why I wanted to think about 2017 and that we're now 2025.
Yeah, a lot's happened since
Yeah, a
then.
lot's happened. Did you have one thing?
I just wanted to say that in terms of recording, every single time now that I go to the doctor, the doctor records what's going on. Now, I see the results of that in the MyChart thing that I do. So that I have to give the informed consent.
If you're in person, the laws don't speak to recording, I don't believe speak to recording an in-person visit. These laws are specific to telemedicine and audio-only telephone. I do think in practice, providers have been asking patients before recording, and there may be standards of care in their professional regulation that require that, but I'm not aware of anything in statute that requires.
Okay.
Yeah.
I just want to make something.
Mari, did you want to clarify?
Yeah, I think, I'm hearing recording as documenting in the medical record, not an audible recording. I don't know
What
I
it
don't know
is this.
any of my providers that make recordings of like verbal audio recordings of our visit. I don't know if
I
anyone.
believe they have started doing some
This
where it transcribes in real time.
puts it right on
And
the
then-
table and says,
So
And
a
then turns it into a
transcription
note.
is different than an audio recording. It doesn't
All right.
store it as sound. It translates the sound into words.
no, he has,
Yeah, there's an app, they use apps
No.
that take the verbal sounds and turn it into writing on the paper, but they're not saving your voice and her voice.
that's not what he told me.
It's,
He asked me, he says to me specifically, do you mind if I record this?
And it may be what is actually
It
being
may
done
be
with
the
that
same thing
recording is
else.
what you're
It is
saying.
the
It's hard to know.
transcription.
It's hard to
It
know.
may be that there's an app or something someplace, but
providers all the time do use transcription applications and software to turn the spoken word into a note. It's for efficiency for their.
anyway, all I wanted to know is, informed consent. If I'm on if I'm having a televisit, I would have to give informed consent if the doctor said, do you mind if I record this?
If they are creating a recording, you cannot, there is no option under current law to consent. Under no circumstances can either party create a recording. Whether it would be interpreted, whether it should be interpreted as a transcription in real time as you're talking.
Yeah.
Is that a recording for purposes of the statute? I think you could make arguments either way. Technology has evolved beyond what the word
Yeah, I trust-
here necessarily.
Yeah, I think if and when we take testimony on this, we will have people come in and sort of explain to us in practice what emerging technology is doing.
You may want to make decisions and we can be clear in our description of what is and is not permissible with or without consent.
Any other questions on our brief history or our lengthy history of telemedicine and telehealth and, all right. Thanks, Jen. Thank you, Jen.
You can
Let me know if you ask your provider, are they actually saving audio recordings of your visit?
I don't
Think
I think it's saving, yes. So we puts it in the right.
Okay, so let's move on. So our committee assistant reached out to various people who have sponsored bills that are now on our wall, and they thought, maybe we could take a few minutes and speak to them if they'd like to present to us the bills that they have. Sort of maybe explain what they're hoping to achieve, the reason they submitted the bill, and, give us an overview. And I think first we have Representative Chapin, So if you want to come on up and just introduce yourself to us. And since we have people coming every 5 minutes, we're not going to go around and introduce ourselves to each other. So let's hope we all know each other, but you can introduce yourself.
Thank you, Madam Chair. I'm Ella Chapin, representative from East Montpelier. I represent East Montpelier and Middlesex, and I sit on the House Environment Committee. I am going to share a little bit about my thoughts. I wanted to start with, so I'm talking about H40, which is a freestanding birth centers bill. I want to start with just explaining what a freestanding birth center is. It's a healthcare practice or professional space apart from and not owned by a hospital, providing labor and delivery care for low-risk pregnancies by a licensed professional, typically a midwife. And in addition to labor and delivery services, typically they often or usually provide prenatal care, postpartum care, and related services like childbirth education classes, lactation consulting, or other services that are related. So what does this bill do? H40 really enables this option, freestanding birth centers for birthing people, improving outcomes and affordability. So H40 specifically would exempt freestanding birth centers from the certificate of need process, thus allowing midwives to have an office setting for their practice where they can, in addition to other services already allowed, they can provide birth and labor and delivery services. And midwives are already required to have a license to practice in Vermont, but this bill would also create a licensing structure for the facility within the Department of Health. That ensures facilities are safe and following national best practices in care and operation. So I want to tell a bit of a personal story to explain sort of why I'm at the front of the table with this bill this year. I have 2 children, both of which I gave birth to. So I've had 2 births. Both were low-risk pregnancies and natural births that didn't require any interventions, although you don't know that ahead of time, of course. You can assess that a pregnancy is low risk, but you can't guarantee it's not going to need any intervention. I also have a condition that results in a highly reactive nervous system, and I find hospitals to be very triggering places that make it very difficult for me to feel relaxed or comfortable, 2 things that are somewhat important in the birthing process. So I knew I wanted to work with a midwife for my pregnancies for a variety of reasons. And that really a freestanding birth center seemed like the best option to me. But I lived here in central Vermont and there wasn't a freestanding birth center in any reasonable distance for me to travel to. I did have both my children with midwives, one in a hospital in central Vermont and the other at home. My second birth feeling like, okay, I did this in a hospital. Now I feel more comfortable doing this at home, but I really didn't feel comfortable having my first child at home. I really would have preferred to be in a midwife's professional setting with all of the things that come with that. So that's a little bit about me and why the option that I was really looking for in birth, which is like not a medical crisis. It's, you don't need to go to a hospital to have a baby. Some people do, but most people don't. And I really believe that birthing people should have all the options on the table, and that in Vermont right now, we're really restricting those options. So that's what's motivated me to bring this bill forward. I want to acknowledge that this is an updated version of a bill that many other legislators and advocates have been working on. So it's not a brand new bill in that sense of the word, but it has been updated for this point in time. And I really think that this point is a really opportune time to make some of these changes. So quickly, some things about the bill or the concept. Birth options, pregnant people in Vermont really only have 2 options, hospital or home. Vermont's one of the only states in the country that does not have birth centers. We're surrounded by states with birth centers. And in fact, there's many right over the line in New Hampshire and Massachusetts, for example. New Hampshire has had birth centers since before 1980. And Vermont loses midwives and birthing people to other states. I'm sure it's not, crazy numbers, but this is workforce and opportunities that we're missing out on here in Vermont. The data is really very clear at this point of the benefits of low-risk births occurring in freestanding birth centers rather than hospitals. There's improved outcomes very clearly for both pregnant people and newborns. And those improved outcomes are particularly significant for our most vulnerable populations, including people of color and trauma survivors. I just can't underscore how important it is to consider that we're not providing a birthing option that is best suited to some of our most vulnerable birthing people. Births at birthing centers also are now it's clear that they cost significantly less. And that's means affordability for individuals and families, but it also means affordability for hospitals and insurance. At this point, is pretty clear. So at this point, we really should be supporting the full spectrum of reproductive rights to birthing people. We should be creating lower cost options where we also will get better outcomes. And this really will save money for Vermonters, Medicaid, health insurance. And I think you're seeing that in some of the data and reports coming to your committee at this point. It also creates, I just want to be clear that this bill does not create any requirements. It only creates options. So it does not require any of these freestanding birthing centers to be stood up. They'd largely be entrepreneurial midwives creating their own small businesses in their communities. And that Medicaid and other insurance cover midwifery care and births in freestanding birth centers all across the nation. And that really, this is also an opportunity, while maybe somewhat small in scale, it's clearly an opportunity to recruit and retain healthcare workforce here in Vermont, rather than resulting in people going out of state to provide these services or to go and receive the services. So hopefully that's a bit of an overview on the bill, and really appreciate your committee's consideration of this among many other important issues. And hopefully we can move this forward this year.
That's great. Thank you. We talked about birthing centers. Leslie said she was opening a can of worms, and it turns out she wasn't, because they have a slide on it from the Green Mountain Care Board on birthing centers. So thank you very much for coming in. Wendy, did you have a question?
Is there a lot of interest from midwives on doing this?
Yes, there is
Okay.
quite a bit. And I'm sure if you take up testimony on this, you can hear from them.
I think today, just because we're going in 5-minute increments and I want to give the presenters as much time, unless there's a question specifically about the bill, let's hold questions.
Anybody can follow up with me anytime. I'm happy to.
'Cause obviously a lot of questions would come out in any testimony that we took.
Okay.
Do you have a fact sheet? Would you like me to pass them around or just leave them on the side?
Why don't you leave them on the table and we can each take
We're
one,
doing here.
or we'll pass as we surround.
Thanks, Ella.
Thanks, Ella.
Thanks for listening. Thanks, all.
We're House Healthcare and we use first names in here, so thanks, Ella.
Pleasure. Thank you.
Yes, please. I'm seeing Troy.
Hi,
Hi. So let's go with Troy.
I have two.
Troy's got two.
They're in consecutive order. Which is kind of fun. Can I jump in?
Yes.
Hi, for those of you who have not met formally, my name is Troy Hedrick. I'm a representative from a section of Burlington, kind of around the hospital and the university, and then down the hill towards Winooski, down the hill towards the Old North End. That's my district. I have two bills. I'm going to do these quickly. The first is H55. This is an act relating to coverage for fertility treatment and gender affirming healthcare services. So let me briefly just do what this bill does and what this bill does not do. And then I'll talk about why I think it's necessary. So H55 expands health insurance coverage for gender affirming healthcare services in Vermont. It also ensures fertility related services to be covered by both private health insurance plans and Medicaid. This directs the Agency of Human Services to seek federal approval to include fertility services under Medicaid. It also prohibits insurance barriers that delay access to gender affirming care, such as requiring extended hormone therapy before surgery. This also then requires the Department of Financial Regulation to report annually on compliance and access to these services. What this bill does not do, it does not mandate coverage for experimental fertility treatments. It only establishes medical practices. It does not impose non-medical costs. So costs like egg or sperm donors, cost for surrogacies. It does not impose those costs on insurance providers. It does not create any new state-run program. It works within the existing health insurance structures. Why I think this bill is necessary. Gender affirming care is recognized as medically necessary by major health organizations. However, there are still very significant insurance barriers that limit access to gender affirming care. Many Vermonters face infertility challenges, and current coverage is inconsistent at best, and oftentimes very inadequate. And very simply, it's just a matter of equity, making sure all Vermonters who have medical needs have access to covering those medical needs. Will this increase insurance health costs? I think minimally. I think that's an important question for this committee to ask. But given the number of Vermonters who seek fertility services and gender affirming care relative to the broader Vermont population, I don't think, or it's not anticipated that this would have a significant cost increase on insurance costs. And in fact, this sort of preventative early medical intervention in the long term, I think it's important to balance in the long-term healthcare costs as well. Does this require religious organizations to cover procedures they object to? The answer is no. The bill does not override any existing federal or state laws that would allow religious exemptions for certain insurance providers. Will this apply to Medicaid recipients? Yes, but only if federally approved. And that's not currently the case. The bill directs Vermont to request the state plan amendment to include fertility services. And how does this impact businesses that provide health insurance? It does create pretty clear guidelines for coverage, reducing administrative burdens that might associate with that. And many large employers already offer these benefits. So I just try to anticipate questions. That's what I came up with. And those are the answers that I personally have for those questions. But I would imagine you all would want to continue to ask those questions and to ask them with a little bit more depth. That's what I've got. This bill ensures all Vermonters, regardless of income, have access to the healthcare they need. It removes arbitrary insurance barriers while staying within medically established guidelines. Expanding coverage for these services supports health equity, affordability, and aligns Vermont laws with current best practices in healthcare. That's my pitch on H55.
Great.
Want me to switch gears?
Thank you. Yeah, let's go to 56.
H56 is a little more straightforward. Well, I mean, I think they're both straightforward, but this is an act relating to establishing an essential medication stockpile for reproductive and gender affirming care. This bill ensures the availability of essential medications for reproductive and gender affirming healthcare by requiring the Vermont Department of Health to establish and maintain an emergency supply. The goal is to safeguard access to critical medications, particularly in face of potential supply chain disruptions or policy changes that we might anticipate from federal legislation. What the bill does and what the bill does not do. Let's do what the bill does first. This requires the Department of Health to assess, to purchase, and to maintain a stockpile of essential medications for reproductive and gender affirming care. It covers medications such as puberty blockers, hormone therapies, contraceptives, and medications for pregnancy termination. Also ensures that these medications are equitably distributed across the state with priority given to rural and underserved communities. It directs the Department of Health to establish rules for procurement, storage, distribution of these medications, preventing waste and ensuring regulatory compliances. It also mandates an annual report to the General Assembly, our body, detailing the supply levels, medication utilization, and any new projected needs that come from the program. And then there's emergency rulemaking opportunities within the bill as well to ensure timely implementation. What it does not do, this bill does not require or force any individual or institution to dispense or administer these medications. It does not mandate any changes to existing healthcare provider practices or require any entity to participate against their will. It does not increase or decrease existing legal access to these medications. This is just about supply stability. That's really all this is about. It does not expand any current policy. And it does not use the stockpile for non-medical purposes. Its sole function is to ensure continuous access to essential healthcare. That's all really. Anticipated questions. Let me burn through these for you quickly. Why is this necessary? Mostly, I think this is anticipating supply chain disruptions and tries to get ahead of that. Also anticipates restrictive policies in other states and manufacturer shortages that occur because of that. The stockpile ensures that Vermont residents maintain uninterrupted access to these important medications. How will this be funded? The Department of Health will determine the funding needs within the existing budget. Leveraging potential. I think that's a big question mark right now, federal or grant opportunities, especially as we learn about grant opportunities and what's happening across the country. Does this force any provider or pharmacy to stock or dispense these medications? The bill does not. The bill only ensures that a state-managed emergency supply exists for distribution as needed. What oversight is in place to prevent waste or overstocking? The Department of Health will implement inventory rotation protocols, an annual report. They'll track supply, they'll track demand, and they'll track distribution. And again, there's a report to the Assembly for that. Why prioritize reproductive and gender affirming medications over other health needs? These medications are uniquely vulnerable right now to supply chain issues and political pressures. Similar stockpiling efforts exist for other critical health needs, such as vaccines and various emergency treatments. So it just brings these two types of medications into those preemptive strategies. Quick and easy.
Thank you.
Yeah.
And we were pleased to see in budget adjustment, the Department of Health, they do for pregnancy,
100,000?
100,000. And we unanimously approved that
Wonderful.
in our budget recommendations. So I know it doesn't go as far as it should, but we were pleased to see that. Thank you.
Yeah.
Thanks for coming in.
Hit me up with any questions. Yeah, I'm in the building Tuesdays through Thursdays.
Yeah. Thursday, maybe.
Or Fridays.
Sorry, thank you. Sorry, couldn't help it. Bob, you want to come on up?
Thank you for the time to talk about the bill.
Yeah, we, just to let you know, we had a preliminary discussion on the history of telemedicine before you came in with our ledge council.
I am really sad to have missed that. So just a quick run through. This is almost an administrative issue. Telemedicine in Vermont is dealt with differently than our border states to some degree, in that recording is prohibited in some circumstances. This basically removes that prohibition with the agreement of both the provider and the patient. Functionally, what it does is allows the electronic record system to more effectively record the notes and allows your physician to look at you while you're talking about what's wrong with you, as opposed to typing on their little computer, which makes everybody feel a lot better. So it's came to me through my wife and my brother-in-law, who worked at the hospital, because they weren't allowed to do certain things, and that was a pain in the neck. And then I discovered that other people had also taken the issue up. So the bill is kind of a compromise between several legislators.
Just because I know we had a lot of questions around the difference between recording, transcription, some of the use of new programs. Can you describe a scenario that that something would be recorded and then how it would be used?
My understanding that is historically, and one of your committee members may also be able to address this, in a patient interview process, recording would sometimes be used and then originally sent to a transcription service, and you'd get the note back where you'd have to approve it, make corrections, send it back. Now it's progressed to the point where I think they're on the verge of saying it's artificial intelligence that actually listens to your interview, and you say, well, on physical exam, I noticed blah, 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 and it's smart enough to pick out those particular waypoints and record them on your chart, and you get the chart back to approve at the end of the day. So it's a pretty significant and noteworthy leap in technology at this point.
Mari.
I think, I'm sure we'll get into this when we take testimony, but I think one thing we'd want to be sure of, I know there are applications that I use at the bedside, for example, taking images of patient wounds that are uploaded directly to the patient's chart and are not kept on the device. So I would anticipate that we would have the same protections in place for transcription audio to voice to word.
After, I mean, the fix seems to be relatively simple, just to get an agreement between the patient and the provider to be able to use the technology. I thought it was going to be a big hoop to jump through, but it turns out it's not. That's a nutshell.
That's great. Thank you for introducing it. And I anticipate that we will be learning more about it. Okay. Thank you, Bob.
Thanks, Bob.
Good afternoon.
Yeah, thank you.
Don't freeze.
Hi, Rebecca. Come on up. I explained to everybody, we're super casual in house healthcare. Everybody's first name.
O2 level in this room, it's about 10 points lower than what's in the hallway, just letting you know. Seems like it.
Oh, no.
No, it's
we're
not good. It means you don't have enough air turnover in here. We're gonna ration so that you can continue to do your good work.
So,
Sure.
Okay.
Recording that?
It's an OSHA violation.
Hi, welcome. You want to tell us about H82?
Sure, I will. First of all, thank you for having me in, and thank you to Jennifer Carby, who did an amazing job of generating the short form version here. Your brilliance surpasses anything I could do. Thank you so much for having me here. The purpose of this bill is to build on the amazing work done by this committee around Act 167 and looking at sustainability and affordability, which is incredibly important to all of us right now. We know that the affordability or rather unaffordability of our healthcare system is affecting everything now, from property taxes to wages, to school budgets, to small business viability. It's also, even as we are feeling it's too expensive, it's undermining access to basic care, primary care, mental health. I like to tell people there isn't a dentist left in Orange County, and good luck getting an appointment in Windsor County, where half of my towns are, because the backlogs are so great. This bill, this is repetition. There is an online bill introduction that you can look at, and I'm using the tactic of repetition because I know that works. But the basic problems that we have are that Vermont has some of the highest healthcare costs in the country. It is now crowding out everything else that matters. Healthcare costs, again, are one of the primary drivers of cost in other budgets, and we're going to be paying for nothing but healthcare soon if we aren't careful. But despite this high cost, many of our communities can't provide or are suffering from lack of access, and we are losing services. But even more importantly, I think it needs to be said, we can't expect the federal government to come in and rescue us at this point, because all indicators are that if we don't see the same level of federal investment, our commercial crisis may get worse. And we know that we already have our insurers in trouble. So this bill tries to address these problems by creating a mechanism for a statewide plan and an independent regulator who can help build the solutions that we need right now and that Vermonters desperately need, from school boards to people trying to just pay their bills at home. So H82 directs a modest proposed redesign and small investment that will enable the state, through its healthcare regulator, the Green Mountain Care Board, to achieve the estimated $300 to $400 million of potential savings that were identified in the Act 167 report, and also shift those investments to build a strong community-based healthcare system that would improve affordability, access to care, healthcare quality, and including in rural areas. And we are seeing huge gaps and huge risks right now in some of our areas that are, I would say, poorly served by markets. To make sure this happens with bipartisan and broad stakeholder support, the bill strengthens the role and capability of the state's nonpartisan independent regulator, that is the Green Mountain Care Board, to lead this work. And it does this by establishing a division of planning and evaluation at the Green Mountain Care Board. And obviously that will need resources to make it work. Building on that report, this division will identify the likely causes of rising costs, declining access, and uneven quality, and recommend a specific set of steps and procedures to address those. It will prepare a state of the state report on healthcare costs that answers the question, how much does each Vermonter spend on healthcare, and how does this compare to other states, so we can have that data available to you as you make your oversight decisions. And to move it forward, it will require the division in its work with stakeholders to develop and present a strategic plan for how to improve Vermont's healthcare system. This plan will include specific recommendations that the board and others can take to increase affordability, reduce costs, and improve access. We have to move from studying the problem to actually solving the problem right now. And for that, we are going to need a stronger independent agency that can do that work. It also recommends steps that can be taken to enable the board to effectively exercise its current budget oversight and rate-setting authority to align the hospital strategic planning process and budgeting with the statewide strategic plan, and ensure that healthcare spending growth remains at or below the rate of growth of the state's economy. So trying to set some concrete goals that we can try to hit through a more strategic planning process. Finally, it does provide the investments. You can't, I own a small inn. If we don't invest in new sheets, we do not have customers. Sometimes you have to make an investment to get a return. But if you've looked at some of the work that the Green Mountain Care Board has done, the return is there. A small investment will yield huge benefits to the state of Vermont, and our communities need these right now. And, again, we saw, a 1 year increase in school budgets of $100 million. We just heard testimony across the hall. The Secretary of Administration came in and said there were unanticipated healthcare related and unbudgeted healthcare related expenses in the BAA, just the BAA, of well over $100 million. We cannot survive this. We have to address that. And for that, we're going to need a stronger regulatory agency that has your oversight, but also has the resources to do the job that Vermonters need it to do. If the committee is interested in pursuing this, I would be happy to provide you with a list of some of the people I spoke to, who contributed to developing this, and who might be willing to come in and testify. And I can't thank you enough for your work on this most important of topics.
Thank you. Thank you. I love that list.
All right.
I would too. I know I'm the one that said, let's not do questions, and I keep asking questions. Do you sort of envision this as, the concept behind the Wyman report of hospital sustainability and sort of expanding it to, the entire system of care within, and the Green Mountain Care Board do sort of that sort of development, report, strategic thinking for the whole system of care, right? And utilizing the savings or the anticipated savings in the hospital sustainability to then support all the other community levels of care, and then strengthening Green Mountain Care Board's regulatory authorities and Okay.
Yes, and I think.
I love it.
And I think that was very well done. Next time you can present the bill. And I think the point is, we have a balloon problem here where when you squeeze one part, it's going to pop out someplace else. We need to develop the ability to think systemically about this issue. And if we actually can't avoid avoidable costs, and we will be treating people at the wrong level in the system. And we can't afford that. Right now, it's not good for our budgets, but it's also not good for population health. So absolutely.
Leslie, did you structurally, so I could picture it, are there other divisions in the Green Mountain Care Board? And what would be the operations? Who would this sit under? How would that work?
My assumption is this would report to
Owen. Chair Foster.
To Chair Foster.
Or the,
Um,
or the
but it-
BPD.
but-
What's the order?
I deliberately did a short form bill so that you could work through some of these decisions if you wish through your testimony. It is clear that the division of planning needs to be closely related to some of the analytical capabilities around evaluating budgets. So there is some overlap there, and I would be happy to give you the longer version that was in the request, and that starts to tease out some of those details as well.
That would be great to have it, so we could be thinking about things.
Okay, I
Yeah,
will do that.
both those things, I guess.
Okay, I will be happy to share those with you.
Thanks, Rebecca.
Thank you so much for your work.
Marty, you're gonna change seats?
I am. I have to stand up. Everyone's
Thank you.
down.
Thank you.
Take care. Thank you very much. Shall I introduce myself?
Yes. Would you like us to go around the table?
Representative Cordes from Bristol, and I think I win the prize today for the most bills introduced into house healthcare. I'm going to touch lightly on them and re-emphasize that detailed questions probably would be better for when, if and when the bill gets taken up. We can ask those questions of the folks the stakeholders that come and testify before us. First one is H96. Earlier today, you heard from the Green Mountain Care Board about the Certificate of Need process. This bill, so the Certificate of Need process, pretty much what it says in the title. The Green Mountain Care Board used to be BISHCA. A healthcare entity has to have approval through the Certificate of Need process for a number of things: purchasing property, purchasing expensive medical equipment, and that's so that there can be state oversight of our healthcare system and make sure that there isn't redundancy of equipment, redundancy of care, and just doing our best to make wise use of folks in Vermont that live in Vermont, our healthcare dollars. So what this bill does, the Certificate of Need process can be quite onerous. And you heard earlier from Representative Chapin about the freestanding birthing clinics. That's one of the barriers that has kept freestanding birthing centers from being established in Vermont. So what this bill proposes to do is increase the thresholds, the monetary thresholds by which the Certificate of Need process would be triggered. And that's essentially it. I don't know that I need to go into a lot more detail. I can say that a number of stakeholders worked on this bill, so it's already had significant input from hospitals, private care providers. So okay with that one?
Okay with that.
Next one is 45 pages long. And personally, I want to say, so this is H71. And it has to do with healthcare real estate, financial, healthcare institution transactions, the state of Vermont. H71, I think, is probably the most important bill or critical bill that we'll work on in this committee, and I believe it will be taken up. To set the table, we know that our Vermont's healthcare system is in a very precarious place. We have multiple hospitals that are in the red, and in difficult financial places. So that's the table being set. The reason we're looking at healthcare entity transactions is because there are other entities called private equity firms that over the years across the country have taken advantage of distressed hospital systems in particular, but can also be long-term care facilities, any healthcare entity that is struggling. And they've done numerous things, like they purchase distressed hospital properties in areas where a critical access hospital is really needed. The people in that community may have transportation difficulty and difficulty for other reasons accessing care, and they'll swoop in, purchase these properties, some cases flip them and turn them into gentrified hotels, and completely removing healthcare from that community. We do have private equity buy-ups in Vermont. You'll know some long-term care facilities have been purchased by private equity firms. We have a healthcare center in my own town in Bristol that was purchased through private equity. There are many documented very negative consequences for the purchasing of healthcare systems by private equity firms. Private equity firms are not healthcare systems. They know nothing about healthcare. They know a lot about money, how to work the system so that they can make profits by consolidation, by the other thing that I mentioned earlier. So they can make a lot of money from distressed healthcare systems. So what this bill does, currently Vermont has no control over these kind of transactions in Vermont. So this bill sets up a really strong oversight and protections for our systems through the Green Mountain Care Board and the Attorney's General Office. The Attorney's General Office would focus on enforcement. So I'm not going to go into full detail about how it does that. We'll get into that when we do a walkthrough of the bill.
Thank you. Thank you. That was a great synopsis of 74 pages, I think you said it was. 47?
I forgot to mention, so I did mention one anecdote about hospitals that get flipped into hotel chains and systems. If you search for this issue, I think there was in either Connecticut or New York, Steward Health Systems was purchased by private equity, and there were some horrible outcomes with patient care and preventable patient deaths. Infection rates, and one hospital that was infested by bats. Directly related to
babies.
Yeah.
Yikes.
All right. The next one is H75, and this amends current statute around the Medical Aid in Dying Act that we already have in place. And then additionally, do not resuscitate and coast orders. And those are agreements that providers and patients make in conversation with one another about how they want to be cared for if their heart stops or they stop breathing. So currently, we'll take the medical aid in dying portion of this and not the DNR cold orders. Currently, only physicians are allowed to activate and approve and prescribe the necessary treatment for medical aid in dying. And this bill would propose to authorize naturopathic physicians, nurse practitioners, and physicians' assistants to do so. And just a reminder that in Vermont, we're fortunate to have a strong group of naturopathic physicians. I think they're preferring to be called naturopathic doctors now, who provide they're primary care providers, and they're very much needed in our communities, and they're providing really important primary care services. And then for the DNR COLST orders, currently, I believe physicians, nurse practitioners, and physician assistants can do those, but not naturopathic physicians. So this would propose that, again, naturopathic doctors are primary care providers. They have the same kind of relationship with their patients. They know them well, and they should be able to perform that function with their patients. Okay, that's all I want to say about that. Moving on to H80. H80, this will modify the role and duties of the Office of the Healthcare Advocate, primarily by increasing, first of all, recognizing the critical importance of the Office of the Healthcare Advocate in representing all of us that use healthcare in Vermont. And in order to do so, the office needs access to critical information that right now different entities in our healthcare system are not necessarily required to give the office. So this would, there's strong confidentiality language in here for patient protection as well as proprietary information protection. But it still gives the ability for the Office of the Healthcare Advocate to have information that they need, especially in a timely fashion. And H79. So H79 is about community-based doulas, and I would refer you to the doula report that came out, I think, in January of this year. In the Office of, I believe it was required by a bill we passed last year. The Office of Professional Regulation and other stakeholders did a great job in this report, and it's really helpful in understanding why we're introducing this doula bill. So doulas in general are people who are trained to help a person go through, usually they're referred to perinatal, around the time of birth, before birth, during birth, and after birth care. You can also hear the term used in terms of in the dying process. We're not talking about that. And in fact, we're talking about a more specific group of doulas than the general concept of doulas. And we're talking about, in this bill, community-based perinatal doulas. There's unfortunately a lot of evidence that birthing outcomes for specific populations, the outcomes are getting worse, like increased mortality, morbidity, meaning bad medical things that happen, like extreme loss of blood, infections, hypertension, strokes. I know we just heard earlier that the birthing process usually doesn't have to be a highly interventionalized process. And there are, I've seen in my own role in the cardiology unit, many otherwise healthy young people who have delivered ending up on my unit. So there are medical complications that can happen, and there's a lot of evidence that the care and the attention of a doula through the perinatal process will reduce those negative outcomes and reduce mortality. And the populations where these negative outcomes have significantly risen in are people in the rural communities, the Black communities, Native American communities, and otherwise marginalized communities. So this bill does two things. It establishes a definition of what a community-based perinatal doula is, and it begins the process for what the legislative committee that wrote the report about doulas recommended that of the three possible regulatory processes that the Office of Professional Regulation could require, one would be the least restrictive, and that's registration. You just register your name and your business with the state, but there's really no enforcement with registration and no protection for Vermonters through the Office of Professional Regulation with that lowest registration process. The next one is certification. The most extensive process is through licensure. And what the legislative advisory committee came up with in the report is, and with the stakeholders, doulas themselves, was that certification would be the most appropriate process. So this bill will lay out a process by which it determines how the certification happens. Many national organizations have certification processes that are usually accredited by national organizations, professional organizations. But we need a state-based or state-approved standardized certification process. That's it.
Thank you, Mari.
You're welcome.
And personally, I want to thank you for some of the work that you did on some of these bills.
Thank you.
All right. I think we're all set for today.